Good afternoon, everybody, and thank you so much for joining the IPHAM webinar series again this week. I have the distinct pleasure of introducing our speaker today, who is Michael Wolf, Director of IPHAM Center for Applied Health Research on Aging, or CAHRA. Dr. Wolf's research generally focuses in two major areas: the study of cognitive, psychosocial, and health system factors that affect a person's ability to successfully manage health, and the design of practical, scalable interventions to help individuals and families access, understand, and use health information to make appropriate health decisions and to adopt behaviors. Dr. Wolf, I have to say, though, is nothing short of a force in the world of health services research. Back in early March, as many of us were just beginning to consider how we would try to contribute to our nation's response to the emerging COVID-19 pandemic, Dr. Wolf had already mobilized his incredible team to design and implement new research here in Chicago that would greatly advance our understanding of COVID's impact on our patients and on our communities. We're delighted to have Dr. Wolf with us today to discuss findings of this recent work in his presentation titled The Chicago COVID-19 Comorbidities, or C3 Cohort Study, Initial Findings. Please join me in welcoming Dr. Michael Wolf.
Thank you very much, Dean Ackerman. Appreciate it. I'm very happy to be here with you all today and to share some of our findings from our research that is ongoing. And a little bit is going to be sharing some of our initial work that has already now just been published, and on top of that, give you some ideas of how we're moving forward in the next directions with this cohort that we've created called C3. I'm going to first just kind of have some disclosures to share for some of the industry work that our center does, as well as for my own advisement. And most importantly, I want to make sure that I acknowledge all the people, and I hope I've not missed anyone that is within CAHRA, our center, that is newly minted. So I'm going to take a moment to explain that as well. But the many faculty and staff that have really helped, truly helped make this happen. Without them, this would not be available. So many research staff and faculty through our center, and also our collaborators throughout Feinberg, have really been engaged in this project and continue to be so. I'm very, very fortunate for that. Also want to acknowledge Stacy Bailey, who is the co-lead for the C3 cohort, and want to make sure I give a head nod to that. And also, to stay on the slide for a few more seconds, I do want to give this project could not have happened without an amazing bit of work from the Institutional Review Board, who helped us mobilize very, very quickly. So Lucas Sikorsky, I want to make sure I give a very big thank you for being incredible, especially during this time. And also Christy Kelly-Toman, our division administrator, who helped deal with lots of the navigating of many things after the aftermath of this project. So a quick overview. Again, I want to take just a few moments to introduce our new center as part of IPHAM. That definitely Ron Ackerman has really championed and brought us to the table. We're really happy to be here with IPHAM. And then I'm going to make a quick, backdrop of the C3 study and the story behind it, and its continuing saga. Then give a little bit of background on the C3 methods, how we approached it, and what some of the initial findings from our first 3 waves. We've done this, we've been keeping this cohort together now since its inception, and it's still active, and we're hoping to keep this going for the next 18 months to 2 years. And then I'll give a little bit of backdrop of where this has kind of taken off, not just across the US a bit, but also internationally, where we've been able to link to collaborators. So I'll give a little discussion around that as well. So with that, just again, CAHRA was really founded as a new aging research center at Northwestern in September of 2019. So we are definitely still in our infancy and excited to keep moving forward and expanding. Again, our focus really is on promoting informed decision-making and actions for the best health and well-being. And as a backdrop and why the C3 study was even possible, our research portfolio is very heavily focused on improving the health of individuals, particularly older individuals, who have one or multiple chronic conditions. So that really, again, set the stage for why we were so interested in focused on these individuals who are at higher risk with COVID-19 because of underlying health conditions, and that we already had an active research agenda in that direction. CAHRA has 6 programs. The Health Literacy and Learning Program that is led by Dr. Bailey, the Cognitive Aging Program led by Professor Curtis, Laura Curtis. Dr. Rachel O'Connor is the head of our Psychosocial Support Program, Dr. Marina Arvanitis of our Life Course Health Program. And then we also have a Treatment Adherence Program, and we're fortunate to work with Dr. Mary Kwasny in the BCC to kind of lead our measurement and analysis program. So here's a throwback. Do you remember what life used to be like when we could gather? And this is a wonderful photo I found of prom, which I'm assuming was supposed to happen for many people about over the past few weeks, and of course has not because of COVID-19. But it's almost hard to remember and to reflect back, not even to the beginning of the year, but even like a month ago, what was happening. So, you know, I want to take us back to March 4th, 2020, and that is when we conceived the COVID-19, our C3 study. So, just as a bit of background, you know, pulling from our WTTW Chicago Tonight TV headlines, our Tribune, going into the Daily Herald or Sun-Times in the local areas, what was being discussed? Well, COVID-19 was not sucking the oxygen out of the room as it is right now with every news story, and to the point where it's hard to pick up any kind of periodical, watch TV, and not have it be drowning out by COVID-19 stories as it's happening right now. But, you know, it also is important to recognize that in March 4th, 2020, there were just dribbling in cases of COVID-19, both in Illinois and also in the US. And it really was viewed much differently than it is now and what we're seeing it to be. In fact, you know, I find it interesting on the Washington Post on the day that we conceived of this study, the headline was more about Jill Biden tackling a vegan on the news than it was about anything around the coronavirus. And even the CDC kind of suggested that the immediate risk to most Americans is low at this time. So again, at the time, this does feel like almost like a different era. And COVID-19 in Illinois, you know, what you already know, you know, is, you know, for us, again, getting back to the CAHRA initiative, our focus on predominantly older adults and their management of chronic conditions. You know, in Illinois, you know, adults over 60 represent only 1/3 of the cases, or less than 1/3, but 86% of deaths. And attention is increasingly been directed specifically in Chicago, to the point where the president has called out our city and state due to disparities, you know, in the Black and Latinx communities who have been hit the hardest. And the disparities here have been more novel than anywhere else that we've seen. Cook County is now the #1 county in the U.S. in terms of COVID cases. And throughout all of that, you know, in the focus on infection and all of the ramifications, the direct ramifications of the illness on kind of more higher risk individuals, we were concerned from the standpoint what really kind of drove our interests at the time back on March 4th was among all these individuals that we were working with, most of them with multi-morbidity, how are they going to weather the storm? What is the indirect impact of the COVID-19 pandemic on these individuals who are higher risk, but still need to navigate the healthcare system, still need to still have complex care needs, and still need to be engaged to take medications, engage with their treatment. How is all of this being affected by this pandemic outside their door? So for the C3 study, our research questions were predominantly, one, how are middle-aged and older adults with underlying health conditions at higher risk for adverse outcomes for COVID-19, how are they responding to the pandemic? But then two, we wanted this to develop more into, what, if any, are the consequences of COVID-19 on these individuals' health status and their ability to self-manage their chronic conditions, which they need to keep doing. And that really was the impetus for our study. And there's the plausible causal mechanisms that we were thinking through is, again, our study was devised on March 4th. It was put into play and launched on March 13th. And we recruited for 1 week, which I'll describe in a moment. But the day, basically the day of, after our survey was completed, the first wave, Governor Pritzker had put into practice the shelter-in-place order, which required social distancing in the community, that required businesses to close, and it created alterations in healthcare delivery and access, and for the most part, a more reliance on telehealth measures and keeping people out of the health system to keep it available to care for those with COVID. And all of those things can actually have a dramatic impact on one's access to medications, their mental health, and their lifestyle behaviors. All of a sudden things are shut down. And so from that end of it, we thought that there were some just kind of structural issues that might be at play that could lead individuals to ultimately have a harder time in managing their health due to all the distractions and also restrictions placed on them. And then on top of that, misinformation, I think, was the primary driver for us, because throughout this whole process, I think most of us who work in public health and in healthcare can recognize that this has been, without a doubt, a huge failed public health messaging campaign. And the response has just been fairly abominable. So for C3, our methods were quite straightforward. We had a cohort of patients that already had some baseline uniform data collection, that we knew so much about these individuals already, and also had access to electronic health records. So we could do a very light and lean telephone survey, not having to capture basic sociodemographic data or other kind of determinants of health that we would want to be normally collecting from patients. So we could focus really, at least in the first wave, the interest was to drive at who were, what are some of the COVID specific questions that we had to focus on. We leveraged 5 parent studies that again had the uniform data collection and linked to various EHRs. All patients had 1 or more underlying health conditions, and they came from 5 different academic and specifically Northwestern medicine practices throughout the greater Chicago area, and also 2 federally qualified health system center networks, and that was Access Community Health Network and also Erie Family Health. All studies also had consents that allowed us to reach out to patients for additional research opportunities. So here are the studies that we did leverage that are all within the CAHRA kind of portfolio. 2 were cohort studies and 3 were clinical trials. They had patients that most of the patients had, again, 3 or more chronic conditions. Some would be at very high risk due to immune suppression like kidney transplant or even having chronic obstructive pulmonary disease. The survey in the first wave, again, our thinking at the beginning was every single day the story around COVID-19 was changing. Again, this was the initial outbreak period. Very, very few cases in Illinois, no deaths, but things were starting to escalate. So our goal was recruit as rapidly as we could, and then that would establish the largest sample possible to maintain and continue to follow along. So this was not meant to be a series of cross-sectional surveys. We actually wanted to follow the same patient's experience over time. We have initially planned for 4 waves at baseline, 2 weeks follow-up, 6 weeks follow-up and then 3 months follow-up. In the first wave, we've had questions that were derived from other pandemic surveys, including H1N1 that we modeled after, including items that reflected COVID-19 awareness and concern, COVID-19 knowledge, where patients had to demonstrate that they could name at least 3 symptoms of COVID and 3 methods for prevention that were derived from, at the time, the CDC website. And then also we looked at related behaviors in terms of patients' change in daily routine, or if they've made plans as a result of the COVID-19 pandemic. And also we wanted to get their level of preparedness and trust in the government response. You can see the items that we have asked up here, and I know this is a lot, but again, this is also presented in the first manuscript that I'll cite in a moment, if you want to see the survey. And also, I apologize, I forgot to also make a note. If you do have questions, I'm leaving time at the end of the survey, at this presentation, to answer any questions. You can direct your questions to the Q&A host in the chat room. So our first findings, again, launched on March 4th and accepted for publication at the very beginning of April, less than 4 weeks after we conceived the study. And this was, again, Annals of Internal Medicine. It is available. Just a quick citation on this. Our sample in this first wave was, again, 1 week of planned recruitment. We had targeted patients with the most recent interview in the parent study. So again, the data that we would want on the patient's attributes would be as recent as possible. So any of the factors that we wanted to kind of pull from the parent study and not that we weren't capturing in the initial wave study, we limited it to patients basically in the past 18 months. They had a follow-up with us, like from 2018 to now. Of around about 1,300 patients that were eligible across the 5 studies based on that criteria, we were able to contact 783 in 1 week. Among those, we managed to complete 673 surveys among those adults. So that was about an 86% response rate. And the sample is, we had mostly older adults, as we were expecting, based on the nature of the studies that we were pulling from. About 1/3 were Black, and 1 in 5 were Latinx, and 11% were limited English proficient. So again, this survey was allowed, we were able to do this in English and Spanish. 1/3 were living below poverty level, 2/3 had multi-morbidity, and about half with limited health literacy. So a fairly diverse group of individuals. So how did higher risk adults respond? Well, 1 in 4 reported being very worried about COVID-19 at the onset of the outbreak. Interestingly, half rated their worry for COVID-19 no more than the same for the flu. 1/3 of participants could not identify 3 symptoms of COVID-19 or ways to prevent infection and spread. 1 in 10 felt that it was definitely or probably likely that they would become infected. So very few people viewed this as something that they were highly susceptible to. 1 in 5 reported that COVID-19 was having little or no impact on their daily routine, and or they were not changing any made plans in response. 1 in 5 also felt very prepared. So most people did not feel very prepared for a COVID-19 widespread outbreak. Again, this was being asked at a time when it was just starting to materialize in Chicago. And only 1 in 10 were very confident in the federal government response. So in multivariable analyses, the story that started to emerge, and again, this wave of this survey ended on March 20th. And when we think now about how prevalent this story is, how common and how we are hearing stories about disparities in Chicago around COVID-19 in terms of how the disproportionate impact, especially in lives lost in the Black community, and now what we're learning more about Latinx communities, those stories were not really emerging at the time that this survey was happening. And while we were working with annals back and forth on the revisions for this manuscript, that is when the stories started to really kind of, we realized we were tapping into something that was in line with what we were also hearing with IDPH data starting to kind of populate. So we found Black participants, those living below poverty level, and individuals with low health literacy felt that they were, they basically felt less likely to get COVID-19. Again, getting back to that notion of susceptibility, were less concerned overall, and yet also felt very unprepared compared to whites, those living above poverty level, and those with more adequate health literacy skills. And those with low health literacy also were more likely to have were more likely to have confidence in the federal government response. And some points I want to just kind of highlight here that's really important is what you don't see are disparities on knowledge or actions. And so in some regards, this notion that maybe this, that there's a lack of awareness that's driving racial disparities is just not the case. This is not an issue of being less informed or taking action. And in some cases, I think the story that we know now is whether it be your employment, your need for public transportation, and also some, we supported a ProPublica Illinois story on this notion that also housing, that there are very infrastructure issues that have driven longstanding disparities that really get at the notion that public health responses that are too superficial and only focused on those issues that are thinking about that this is about better messaging, getting into the communities, telling people what COVID looks like and how to prevent it. Those might be very uninformed and not as useful as what we really need to be thinking about, which might require changes in policy and other things. So thinking about wave 2 and wave 3, we've already completed now all 3 waves and are starting to just process the wave 3 data. Just as an aside, so this is what wave 1 and wave 2 and wave 3 look like in terms of COVID cases, both in Illinois and in the US, and deaths. And I think it gets back to this notion of, do you remember what life was like when we had less than 100,000 cases in Illinois, or let alone 100,000 cases in the US, which was at wave 2. This has exponentially grown, and so we were very interested in making sure that we could continue to follow these individuals as the story is changing at a daily rate, if not faster. So for the 3 waves, we've been able to do very, very well with getting a hold of these individuals. And part of it is maybe that is the lemonade out of lemons here, is that when people are sheltering in place, they're more amenable to be caught, for a survey, and we are compensating these individuals. Again, it was at $10 a wave, and then we increased it to $15 as an incentive that we've been able to get to them just as the survey is starting to get longer, and I'll explain how long it is now and what's in it. I mentioned the uniform baseline data collection that we have, again, across all of our studies with REDCap. We have, because these are all studies within CAHRA, we've been able to kind of standardize our approach on how we measure various common psychosocial determinants and individual factors. So everything from things that we did not need to have to collect, like sociodemographics, chronic conditions, both through self-report we capture, but also have access to validate in the EHR. In PROMISE, with the patient-reported outcomes, we capture physical function, depression, and anxiety. With health literacy, we have the newest vital sign that is a performance-based assessment that we've been able to capture. We also have health activation with the Consumer Health Activation Index, and medication adherence on most patients with the ASC-12. And this is also, we've been able to do deep dives because some of our studies have pretty extensive batteries that we can do sub-analyses with this group in terms of everything from neurocognitive and personality factors for sub-analyses if we wanted to link that to COVID outcomes. In waves 1 through 3, you can see what has been collected in each. And again, Wave one was short by design because we basically committed ourselves to 1 week of recruitment because of the changing nature of the pandemic, and also the fact that we needed to just basically have as light of a survey as possible so it could eventually become this cohort. With wave two, we expanded the data collection to incorporate a very, very detailed assessment designed by Dr. Bailey on sources of information, which captures not only where you're getting, what is the modality that you're getting information, but specifically down the granularity of exactly what information source are you going on to, what website, what TV channel, and how much time are you spending on a daily basis kind of absorbing COVID content. We also got information we also had items that captured COVID-19 related stress and feelings of loneliness and isolation, as well as changes in employment status, knowing that, as we hear the news and the very depressing and very concerning, numbers around unemployment. So looking at socioeconomic changes in someone's socioeconomic circumstance, if they lost work or they had hours reduced, that would affect their finances. We captured that. And then we also started to get at patient-reported self-care capacity, their ability to manage their health during COVID-19 and their chronic conditions, as well as also their ability to access and remember to take medications. With Dr. Marina Serper, who some of you may know was a former GI fellow at Northwestern and is now faculty in hepatology at Penn. She has been a collaborator on this endeavor as well and added telehealth items. So she serendipitously was in the middle of a K award funded by NIDDK focused on telemedicine. So it was very serendipitous that we were able to work with her on this as well and start to understand how, who's getting a telehealth visit, what has been their experience, their desire to continue even beyond, a pandemic. And so that was included and expanded upon and at wave two. And now at wave three, we've kept items from the base wave so we can look at trend data on certain factors. The sources of information did not continue because that was an incredibly long aspect of the survey. But now we're capturing information around medication access and adherence, and also lifestyle behaviors, including BRFSS items to capture physical activity. We also use the audit C to get at drinking habits. We have data on social support and unmet tangible health needs. That's led by Dr. Rachel O'Connor. Patient-reported outcomes are included, specifically anxiety and depression at this point. We're also looking in getting patients to self-report healthcare use as well as avoidance if they needed healthcare but chose not to get it because of fear or concern out of COVID. And with a collaboration with Dr. Richard Gershon and Medical Social Sciences and led by Laura Curtis, we also are including self-reported items for looking at cognitive function and memory complaints. So the survey has definitely gotten longer. Just a brief peek at wave two findings. A few of the themes that we're starting to see emerge at wave two has been differences in how people perceive or report confidence in the state versus the federal government in terms of COVID-19 response. And what we're learning right now is it seems that there's considerably more confidence at the state level. And what we've seen at the beginning in wave one, this very, very low, less than 10% basically of individuals endorsing that they're very confident in the federal government response. That persists at such low levels throughout wave two. Another difference that we started to see emerge at wave two, and again, these findings are still kind of fresh off the press, and so we're still learning right now, is gender differences, where women are not only taking it more seriously, the COVID-19, they perceive the threat more serious than men. They're also more likely to be taking action, including social distancing, almost to the point where they're kind of socially isolated to that extent, where they're not seeing other people, they're not leaving their house as often. But they also report greater worry on a daily basis about COVID-19, and also have greater confidence in their ability to manage their health throughout this pandemic. The other story that we're starting to see that we didn't see so much to the same degree, or at least it's different, is among the Latinx community at Wave 2 in terms of self-managing their chronic conditions. We're seeing that individuals belonging to the Latinx community are more likely to report being socially isolated and more likely to have greater perceived concerns or difficulty in their ability to manage their health and remember and access to their medications. And finally, another kind of developing theme that we're pursuing right now is that the impact of COVID-19 related stress is quite significant in self-management. So patients who say that they're very worried or they're worried a lot on a daily basis with COVID-19, that is also impacting their self-reported perception of their ability to manage their health, to access medications, and also they're also more likely to have had a telehealth visit. So next steps for the C3 survey is we already have 2 additional manuscripts under review. Sadly, not all of journals are able to provide rapid communications mechanisms. So sadly, with a lot of this research that has kind of a time sensitivity element to it, we're not able to, we're still awaiting kind of verdicts on 2 of them, and other multiple manuscripts are in preparation. Some of the directions that we're likely taking, at least right now, with collaborators across Northwestern and also elsewhere as well, is a focus on kidney transplant and looking at how taking a deep dive on certain chronic conditions led by. We're also looking at the following up and trying to kind of report on what we've learned about information-seeking behaviors. Looking at how over the course of the pandemic, since many of our individuals were reliant on caregivers, formal or informal, to assist in their management of their chronic illness, that we didn't know if that has changed or if they have more unmet needs as a result of COVID. And again, that has been spearheaded by Dr. O'Connor. And we're also, again, trying to kind of capture what we've already learned right now, and this is something about to go out the door, which is self-management of chronic conditions, again, in light of the COVID pandemic. We also are partnering with the clinical psychology PhD program that's linked also to CAHRA. We have Dr. Rebecca Lovett is a postdoctoral fellow, currently on maternity leave, but has been working through that period to kind of examine mental health aspects, along with Andrea Russell, Esther Yoon, and Sophia Weiner-Light, all doctoral students in the clinical psych PhD behavioral medicine track. Marina Serper is starting to kind of look at telehealth experiences over time. We also have an emphasis on what's happening to individuals with pre-existing cognitive impairments who yet still were community dwelling. Oftentimes these impairments are undetected, but how is this impacted through COVID and their ability to manage chronic disease? And also working with Dr. Danielle McCarthy in the emergency medicine department on looking at healthcare utilization at this time as well, including the ED. We have an NIA COVID-19 administrative supplement that we are in discussions with right now with National Institute of Aging, and that is going in to continue this study to follow patients for as far out as 18 to 21 months post that initial outbreak phase. And another thing just to kind of comment on that has really been of great interest is we have gotten a lot of requests for additional collaboration. So a lot of the analyses that we've been doing, we are creating, we've been able to create many partnerships beyond Chicago and also internationally in which we can actually start to make comparisons across different areas around some common core elements, most of them coming from the Wave 2 survey. Just to show kind of on the screen where these people are, where we have partnerships, everywhere from Louisiana State to also Dr. Alex Fetterman at Mount Sinai just completed 200 surveys for us that are actually linked to 2 of our parent studies. Jennifer Edelman at the Yale School of Public Health is administering it in New Haven and Bronx, our COVID survey. We also now have partnerships with our colleagues at the University of Edinburgh. Ian Deary and Chloe Fons Ritchie have already finished collecting. They administered our Wave 2 survey to 2,000 older adults in the Generation Scotland survey, as well as Britt Nielsen, who is affiliated with Aarhus University in Denmark, also focused on individuals with chronic conditions. We have an orthopedic surgery collaborator in Dublin. We've got also probably our most significant partner, and we even have a publication out under review with Dr. Kirsten McCaffrey at the University of Sydney, in which they did the Wave 2 survey among Australians. And right now we're working on data use agreements with these sites that have gotten on board to see how we can actually pull this data together and look at these kind of cross-country comparisons. And so I'm stopping short to answer any questions. So hopefully as a Zoom call, this was, it's maybe give you some time back, but I'm happy to answer any questions that you may have.
Thanks, Mike. We've gotten a couple of questions. So Jackie is asking, are there any eligibilities of the participants who will take the telephone survey?
So the primary eligibility is that these individuals were already have already consented and enrolled and engaged in one of the 5 parent studies. And to that end of it, a lot of the individual eligibility criteria, and I can go all the way back to show this sample here, that really just shows what is the, most of the clinical eligibility is centered around where they were getting care and around having certain clinical attributes, including certain chronic conditions or number of prescribed extended duration medications that they've been taking. If it's the question about do they have to have some level of proficiency to be on the telephone, we already knew that they had a phone and we already had the ability to contact them. We had been in communication with them previously to schedule in-person or phone-based visits with them. So I hope that answers the question.
Okay, our next question is, given the protests both among mostly white folks for reopening the country and the protests among mostly the Black community for racial analysis, what are your thoughts and concerns on COVID outbreaks happening as a result, and how might it impact each community differently given what we know of the racial impacts of the virus? Well,
I think I would definitely want to leave a question like that, which is a very legitimate question, to the people on the public health experts and the professionals on the front lines of this, especially in Illinois, where I think we are seeing that kind of split, whether it be in more rural counties down south versus what's in Cook County and some of the collar counties. There are going to be these divides. So, I don't want to have I don't have an answer for something like that. I think that it is very frustrating that we're starting to see a great deal of polarization around this issue when public health really requires us to kind of be in lockstep. If we're not all willing to do it, the risk is just going to continually be there, and we shouldn't be surprised when the numbers keep increasing. So I think as a to be continued and direct the question to IDPH, I would also say that we've got we are all about, in Illinois, we're all about to really start to find out soon what it means to open up with this weekend. As we start to see us move into a later phase, and it's going to be, I think it's scary. I know a lot of us are a little bit kind of feeling testy already, being sheltered in place, but I think many people believe that this has in fact been working.
Okay. From Judy, she's asking, have you found an association between COVID-related stress and adherence?
That's a great question, and one that we are very interested in looking into. So I will have, that would be a stay tuned question, because we just finished on May 22nd. We wrapped up, that was just this past Friday. We just wrapped up the final survey. So we have self-reported measures of adherence at baseline, and again, the ASK-12 measure was put into the third wave that gets at detailed self-report items around medication adherence. So we will be able to look at that. In addition, many of our cohort, many of the parent studies are geared towards medication adherence, because that's an area of research that our team is very interested in, and many of our studies delve deep into it. So we have many objective assessments as well from the parent assessments, and also CAHRA has a partnered master agreement with in partnership with Walgreens. So, you know, granted that may be a bridge too far for us, but you know, whether it be getting refill data to many other things, we've already been talking to Walgreens about some of the interest and directions that they're going. But definitely stay tuned. We are very, very interested in that specific question.
Okay. The probability for a person 60 years old to die of COVID-19?
Well, I mean, going back to the statistics, I mean, so that's a tough question to get at. And I think, like, in the past 24 hours, there's been lots of revision around the data that you might have been hearing in the news. And as many researchers are reevaluating, you know, how common is COVID in the community? So if the denominator is increased, and does that shrink the risk? Is it not as fatal? I think most people are still saying, and again, many of you can correct me if I'm wrong, but whether it's 0.5%, you know, what is the death rate? I mean, it's still higher than the flu, and obviously they still are very much geared towards individuals with certain underlying health conditions. And I think the three that you hear most often is type 2 diabetes, BMI, hypertension, among others, I'm assuming. That those over 60 are still at a far, far greater risk when they're looking at death rates. But I would probably direct you to some of the more recent evidence that's been coming out of both Washington, and also data that's been coming out of the University College, or actually Imperial College, I believe, with some of their reevaluation of estimates that are using actually still some of the data that's coming from Europe. But even data that we're starting to get in the US. I think actually Indiana University just also, the School of Public Health, just did a reevaluation, a revisit of how common it might actually really be in the community in the state of Indiana. They did a run on that, and also what might be a more revised mortality rate.
Okay. Any surprising findings regarding the chronic conditions, comorbidities, and COVID cases / impact?
So one signal that we had, and it wasn't surprising, I mean, I think a couple of surprising things for us is that even though our sample is predominantly older, as we had expected it to be, you know, there has not been one age-related difference. Age has never been you know, has ever identified any associations in bivariate and multivariate analyses. We've not, it just hasn't really done it. There really aren't any age differences, which I thought might be, you know, there, because of the messaging that we're hearing. The one consistent thing from the very beginning is those most at risk are older adults. And the evidence, you know, as we've gone through this pandemic and coming upon you know, an initial apex phase, is the story is solidified. And we would have thought that maybe there was greater attentiveness or a sense of urgency that we might have, you know, been hearing from older adults, but that doesn't seem to be the case. With chronic conditions, we did try to do some kind of exploratory analyses to see if there are, you know, certain individuals with certain conditions, especially those where maybe it wasn't so clear what they meant by underlying health conditions at the most, you know, who was perceiving themselves to be at greater risk and maybe more likely to be taking action early on, and what we were calling early responders, because they were trying to make sure they were very clear on preventing their risk of infection. And specifically, we looked at kidney transplant recipients, and I think that was the only population that, in terms of a specific condition, that compared to others seemed to be in the direction that, you know, they knew they were immunosuppressed, they got that message, and so they were definitely more worried and maybe even more likely to take action at the very initial outbreak. And that we didn't play out too much because that sample is somewhat small, but that's one of the reasons why we wanted to work with Dr. Ladner to look at the story more longitudinally. In talking to my colleague, Dr. Edelman at Yale, her interest is around HIV, and I think her hypotheses using our Wave 2 survey was, if she were to, you know, what we're trying to do is to compare her cohort to ours, and the thought being that we're only 10%, you know, like only 1 in 10 individuals thought that they probably or definitely might get COVID-19, that they just didn't feel that it was that susceptible. They didn't, half of people didn't think it was worse than the flu in that first outbreak. Her hypothesis was that with HIV patients, that these individuals are very hypersensitive to you know, these types of health threats, and that we might see a dramatic difference between our two cohorts.
Okay, what telehealth information were you collecting? Were there disparities in telehealth use?
So only about 140 of the 630 or so patients that responded to Wave 2 that we've been able to look at had at that time a telehealth visit. I mean, it's still a good number. Again, that was only like 2 weeks after the initial outbreak week of Wave 1. Definitely a lot more, I believe, in Wave 3, but we haven't yet looked at the data. We have looked at to see if there were any disparities between who was getting a telehealth visit or not. And especially since, you know, again, over a third of our sample was recruited from federally qualified health centers. And to my knowledge, we did not see any disparities in terms of where they were receiving care, or any kind of, there were no other kind of patient factors that were associated with getting a telehealth visit or not, other than the one that did show up in the multivariate analysis that I talked about, which was individuals who were more worried or stressed were more likely to self-report having had a telehealth visit, which you can probably understand why that might be the case. But we do have questions, just as a follow-up to that item. We do ask in detail if they've had it. We want to have them kind of rate their experience, how it compared to an in-person visit, their willingness to continue with telehealth visits beyond the epidemic. And some of the things that we're trying to get more into, that we've added items in Wave 3, are more like about some of the granularity around what might make it more difficult. Because going telehealth, and is it by video, is it by phone? We also ask those questions. Really might have an impact, especially on individuals with maybe with lower literacy skills or older patients, in terms of being able to describe symptoms, being able to interact with your provider. There may be just some inherent difficulty in being able to get what the patient needs out of that visit, and we wanted to really understand that. That data, again, is kind of stay tuned. Again, Dr. Marina Serper at Penn will be leading those analyses.
Will the journals that you do allow you to post a working version on MedRx IV or similar? This used to be taboo, but that is breaking down for COVID research. I
do not know. That's a very good question. I'm not, I would be very, in terms, I know that some of the journals are, including I think Annals, are, you can find the publications and it's open access right now. So the PDFs of the full journal article can be accessed through a Google search, and there aren't the restrictions that there might have been before, where you had to go through PubMed or have a subscription to the journal to access it. So we had not placed these publications in that. We are trying to target open access journals and those that have rapid communications to get this out quickly. So that has been our approach, but I don't know the answer to that question.
What public health intervention your study findings recommend?
Could you repeat that? I'm sorry.
What public health interventions do your study findings recommend?
Very good question, and kind of alluding back to like the ProPublica story. I think that, granted, some of the general messages before kind of taking a deep dive into any specific group of individuals, that it did show that we probably had not the clearest communications in terms of getting it right when it at a moment that was very, very critical to really explain to people what they need to do. So I think it's getting better, and I think it's getting better at a state level. So depending on what state you're in, the message may be very, very clearly articulated, and in some states it's not. And so I think a more unified approach to how we explain to people what they need and why, what they need to be doing and why, and operationalizing what shelter in place actually means, social distancing. I think that could be done better. But that's just at the foundational level of just making sure people understand what they need to be doing and also why they need to be doing it. I think the other issue is especially on the notion of the disparities that have, very sadly emerged in our state, in Chicago, is that we need to think bigger. We need to think much bigger, and we need to be doing things. I mean, it was good that I think the mayor took action fairly soon after the stories were starting to emerge very, very clearly that this was not a unifier in terms of aid. Not all were getting affected equally. And with greater testing sites put on the south side, I think those things were happening very, very quickly for the most part after the attention was quickly raised on these attentions. But I think like there needs to be a lot of infrastructural change. How do you protect the safety long-term of essential workers, people who may be, who are still socioeconomically disadvantaged that have to work? How do you manage and protect safety on public transit? How do you address the notion that people who have more than one person in a room in a crowded household? I mean, these are things that just require much bigger thinking, that require policy changes, that require a very multifaceted response if you want to actually get this right. So not to get, I mean, it would probably be a full day session for us to really think in detail all of what we really need to be doing differently. I will say that I feel proud to be in Illinois, and I feel like Illinois has been listening to public health professionals. Its leadership has, and I feel like I hope we continue to do so even beyond this weekend.
Great. Are you collecting numbers of members in the household as well as single dwelling versus multi-unit dwelling?
We are. That's a great question, and I apologize if I left that off the table of the data to be collected. We are capturing, especially since things that we thought we could rely on at baseline, we recognized, and I give a hat tip to both Dr. Stacey Bailey and Rachel O'Connor for this as well, in putting items in that really address aspects of, not only if there's any change in their household status, but we want to make sure we had accurate information about who was in the household. We do have information about also if not only just if it's overcrowded, but also who's sheltering in place alone, especially if you're older and you have health needs, given that we're also showing some detriment to living alone as well in our self-management paper. We also started to collect and try to get updates on changes in employment status, as I mentioned. So we think that both housing and employment, there's possibilities that these things might change. and also could have a detriment to COVID-19.
While assessing knowledge, can you say something about sources where people are getting info? Are any sources particularly helpful or problematic?
So I don't want, so this is very much in the wheelhouse of Dr. Stacy Bailey. And so I want to leave, I won't be able to say too much on that because that's a manuscript that is soon to be going out. And so the story that she might tell you is, I think the one thing I can say about our sample is Illinois is a blue state, and it doesn't have as much variety as we think, but as we move to more comparisons with other geographic areas, it might be very telling with some of the questions we have in place. So there's, I think, a good amount of heterogeneity in terms of how much time people are spending on news sources, how many sources they're actually tapping into, and in terms of just not relying on one single source and that being the only message that they're getting without any kind of cross comparison. But I probably want to hold off on that because that is definitely the story that Dr. Bailey would know more than myself.
How many people in this study actually got the virus or died during this study?
So we are tracking that. Their COVID status, we asked them if they have it or think they have it from wave 1 all the way through wave 3. And if they do say that they have it or think they have it, we ask if they've consulted a health professional, if they've gotten tested, what the result of the test, we get that detail. I know at wave 1, very few, if any, 1 or 2 might have said that they had they thought it had it or thought they had it. We also know that at wave 1, very few, if any, knew of someone that had it or thought they had it. And at wave 2, we started to see, I don't think too many people that had it, but a good number of individuals. I want to say almost like 120, 130 individuals at wave 2 said that they knew someone that had it or thought they had it. And again, wave 3 is still fresh, so we have the data and we're very interested. I believe we did a query through the process of the study, in the process of wave 3. And I think we, at the last glance, I thought we still only had maybe only a handful or more of people who not only have said that they had it, but also had consulted a healthcare professional on it. And then among those who got tested, some said that they were unable to get tested. And again, that was between March 27th and April 3rd. At that time, where we had people who thought they had it, but just couldn't confirm it with a test. But also we had people who had been tested and it was negative. So clearly not everybody who just self-reports that they think they have it translates to a likely positive outcome. But we haven't finalized it, but we'll continually to track. We want to, again, with the hopes that we get the supplement, we'll be tracking this for 5 more waves over the next 21 months, for a total of a 21-month span of time, and we'll be able to see how many people ultimately in our cohort do develop it.
Great. Well, it's 12:59, and I definitely want to make sure that we're respecting people's time. There are a couple of more questions I can share with Dr. Wolf privately, and maybe he can respond individually. But thank you so much. Thank you for everybody for coming and staying and for your questions. We will be recording this. I will be sending out a link in the next few days to anybody who registered, which all of you should have, so have your email address. And stay tuned. We have a couple more seminars on the horizon. So thank you, everybody. Bye.
Thank you.